and welcome to Lakeridge Health's inaugural Women in Health Symposium 2025. So tonight, we are making history, not only because this is the first ever Women in Health Symposium for Lakeridge Health, but it's also a sold-out event with organic social media promotion and word of mouth. To my comms team, you know how great that is. But really, I'm so excited that we all get to be here tonight, be a part of something super special and truly unique. So thank you from the bottom of my heart for being here. For those of you who may not know, I'm Shara Santon. I'm the Senior Director of Strategic Communications at Lakeridge Health. I'm honored to be a part of the senior leadership team as well. I've had the privilege over the last couple of months to be co-chairing the planning committee for our Women in Health Symposium, and I'm excited to be your host for tonight as well. We have so much planned for you today, but I would like to start with a beautiful honor to the Indigenous land that has brought us together today in this very moment. So to do that, first we will be starting off with a smudge ceremony and a song, which is a tradition that represents respect, gratitude, and fosters a sense of unity among us all. So to lead this, I'm excited to introduce to you Tina Cole, Jennifer Johnson, Susan Byrne also. Tina is a proud Cedar woman from Alderville with Bear as her clan. She is an Indigenous cultural safety trainer at Lakeridge Health. With 19 years of community experience, she advocates for decolonization, cultural safety, and integrating Indigenous knowledge into healthcare. Jennifer, who also goes by Jenna, is a proud member of Caldwell First Nation and is Anishinaabe, Lenape, Plains Cree, and Michif. She is an Indigenous cultural safety trainer at Lakeridge Health as well, with over 18 years of experience in Toronto's urban Indigenous community, Indigenous rights, and anti-racism advocacy. Susan is of Mi'kmaq Irish and English descent from Gander, Newfoundland, and has over 13 years in community social services. She supports diverse populations, including Indigenous peoples and marginalized groups, and currently serves as the Crisis Intervention Counselor with Victim Services. Please join me in welcoming Tina, Jenna, and Susan.
Kwekwe Deloisigadio Yanela, Muendodem, Wedebaksi, Gander, Newfoundland. My name is She Gathers Flowers by the Water, and I'm so very honored to be here with you this evening. The tobacco is the first medicine of our people, and the exchange of tobacco that we've received this evening from Lakeridge Health is a big honor for us. We know that we need to work in reciprocity in order to change systems from the inside out. And so that gift of tobacco is Lakeridge Health's way of honoring the work that they choose to do with Indigenous communities. That tobacco is sacred and goes before any medicine, and we put that down every single day for our intentions. And so in those tobacco ties, which will eventually go into a sacred fire, are all of the intentions of all of you sitting here this evening. I'm so very honored to be here with my sisters who work for Lakeridge Health, and was so very honored to be asked to do this opening this evening. When we sing and we go into that ceremony of singing, it is our heartbeats, our drums that carry those tunes, those songs, those prayers, those vocables to Creator and to the ancestors to know that we are here and that we have an ask for them to sit with us this evening. When we light that sacred smudge, it's to honor the 4 sacred directions. It's to cleanse ourselves and our drums, which we did prior to coming up here, so that we start everything in that good way. We're going to be singing this Strong Woman song for you this evening. It is our honor and our pleasure to be here. And we want to say miigwech, and we will now sing.
Way up, way
Thank you so much once again, Miigwech, for opening this evening with so much warmth and love. Honestly, thank you. Up next, I'd like to introduce you to Cynthia Davis, who will begin with the land acknowledgement and provide an overview of Lakeridge Health, who we are, what we do, and what our vision is. Cynthia, or Cindy, as we also call her, is the president and CEO of Lakeridge Health, who embodies the pinnacle of transformative leadership within the healthcare sector. Cindy's journey began on the front lines as a registered nurse, instilling in her a profound understanding of patient care at its core. With a distinguished career spanning over 3 decades, Cindy blends her leadership and operational expertise to deliver visionary initiatives that aim to improve generational health outcomes for local communities. And importantly, Cindy is my boss. So please join me in welcoming Cindy.
That's very funny. Thank you. And welcome, everybody. We're so excited that you're here with us. But before we get started, I wanted to do a land acknowledgement. And certainly, following that beautiful music that we just heard, I think this is very fitting for us. At the end of 2024, we saw the passing of the Honorable Murray Sinclair, who led the Truth and Reconciliation Commission all across Canada. And that truth and reconciliation recommendations, and particularly those that are associated with health, are very important to us. And what I say as an organization, when I read the quotes that Honorable Sinclair talked about when he presented the findings of the report, it really is so much work that we have done, but so much that we continue to do. And as an organization, I absolutely am committed to doing this work for this community and for our community at large so that we can move forward with health equity for everybody throughout the Durham region. So with that, I think we'll go ahead and get started. And wow, what a crowd. We're so excited. And thank you to the organizing team and to everybody who came out today to share this inaugural event with us. We're really proud of it. And we hope that this is going to be an annual event for us. So getting started, we're absolutely appreciative of everybody who's joined us. But if I could get some of our honorable guests to stand up, and if I could get you to hold your applause until the end. I want to acknowledge some people that joined us today, and what I would say is these individuals continue to be supporters of all things Lakeridge Health. They are absolutely in our corner for all of our communities and for our region, and for that we're absolutely grateful and appreciative. So if I could get our MPP for Whitby, Lauren Coe. And so, Lauren, please stand, because at the end, I'm hoping we can give an applause to all of you, because you all work tirelessly in our communities, and you're huge supporters of us in Lakeridge Health and everything that we're trying to do to build the best healthcare system throughout the Durham region. And I can tell you, each one of these individuals work tirelessly to support us. So next from the Ajax Council is Marilyn Crawford, who's the Deputy Mayor, as well as Regional Councillor Ward 1. We have Nancy Henry, who's, she's trying to get more applause. Ajax Councillor Ward 2, and Joanne Dice, Regional Councillor Ward 3. And we also have one other councillor, Lisa Bowers, who's joining us as well. So I certainly want to acknowledge all of those individuals. So please join me in their applause. Thank you so much. And so I also want to acknowledge where we are today in the holy month of Ramadan. And so for the individuals that are here with us tonight that are celebrating this, we thank you for coming. Ramadan Mubarak to all those who are observing. I also want to share with you that during our break, we do have designated prayer space. We also have water and dates that will be available throughout the evening. And I know there's many people in the room that have green on. I unfortunately own nothing green, even though redheads usually do. So I would say happy St. Paddy's Day to everybody who's also joining us as well. Somebody said to me, why did you organize this on Patty's Day? I'm not sure that we understood all of that calendar, and we were just really excited to get going. So I'm going to go quickly through this. And there's an agenda on the tables. We're hope that we can share a whole bunch of information, not only about Lakeridge Health, the tremendous women that work in our organization in so many areas you're going to hear from tonight, as well as, the tables in the back to talk about all the things that are possible at Lakeridge Health. We want to hear from you, so there's a code on your table. If you scan it, we really do want to make this meaningful for everybody who took their evening and came out with us tonight. So please provide that feedback. We also want you to stay connected with us. We have lots of social media, newsletters, and if you'd like to be part of that distribution, we invite you to scan this as well so that we can share with you. And then I'm very quickly, because I have a lot of slides, but I'm going to go very quickly. Somebody at my table said you need to put on your fastest voice, and I can probably do that as a Newfoundlander if you haven't picked up on that already. But Durham Region is one of the fastest growing regions in Ontario, and right now Lakeridge Health is the largest community-based hospital system anywhere in Ontario, because of the depth and breadth that we have. And so I know some of you might know pockets of Lakeridge Health. What I want to talk about is the entirety. So you can see we have a system of hospitals throughout Lakeridge Health. And you can see the 5 locations where we have hospitals and growing. And within those, we have emergency departments. The only exception right now would be our Whitley location. And then we also opened a new long-term care home, 320 beds, the first long-term care home in our system, and it's located at our Ajax Pickering campus. And this past year, we also celebrated the grand opening of the Jerry Coughlin Health and Wellness Center. Through the generosity of the Coughlin Foundation, we opened a standalone surgical center in Pickering. And what's interesting about this piece is within this standalone surgical center, we've also partnered with many other providers. So there's 10 primary care providers in that location. There's lab, diagnostics, and soon to be many other things. We occupy the top 2 floors, and we do all day surgery from this location. Not all day surgery for Lakeridge Health, but day surgery is the component that we do at that location. And then we also had a merger with Durham Mental Health Services. And so that gave us a footprint in terms of mental health and addictions throughout the Durham region. And again, makes us one of the largest providers outside of Toronto and Ottawa for comprehensive mental health and addiction services. And each of our sites, what we talk about is the puzzle that we're trying to create throughout the Durham region. So each of our sites would have a designation of a center of excellence. And you can see on this slide some of those centers of excellence that we have. And we'll continue to think as we grow throughout Lakeridge Health, how we avoid duplication and how we bring services, those comprehensive services, closer throughout the entire region, so you don't need to actually travel outside of our region for the care that you need. And again, so for this one, in terms of the mental health I've talked about, I'm really proud of the team that we have, and many of them are here with us tonight. Just true stewards of healthcare, tons of experience and expertise. I get to be the spokesperson for Lakeridge Health, but we are successful because of this team of individuals who work so tirelessly to make our system the best that we can do in so many areas, whether it's quality, whether it's finance, whether it's medical services, and I'm just really grateful for this team. We often talk about, we're a large healthcare organization. We're actually the largest employer in the Durham region. So we're actually one of those economic driving engines in Durham. We have over 9,000 employees, staff, physicians, and volunteers in our organization, and continuing to grow even more. You'll see that tonight we have an opportunity to hear about the jobs that are available at Lakeridge Health. I saw so many volunteers with their blue jackets or aprons or shirts, and all of that is possible because we work together to try and build a better system. So what does it mean when we talk about an integrated care system? And this is our vision, one system, best health. So I described all of those bricks and mortars that we have throughout the Durham region. And when I think about it like that, what we want to do is make sure that they're all connected. And when we talk about a quality of care and a standard, we hope that throughout our region, no matter which site you go to, there's an expectation that you're going to receive a level of care. If you're coming to have, surgery and you go to any of our sites that offer surgery, we will have a standard that is consistent across Lakeridge Health. So that's how we think about integration. The other piece is the people that work in our organization, the ability to move around, the ability to transfer, the ability to complement and support each other. Again, another notion of what integration looks like. And then finally, when we go from a care perspective, integration really to the client, patient, or resident is a seamless continuum of care. And I can tell you we need to work tirelessly on this. We've come a long way, but we still have a long way to go. People expect that we will break down their barriers, that we will ensure that we're coordinated and we do handoffs of care to make sure that their experience is the best that it can be. And so when we describe one system, that's what we mean. And then finally, best health is through all of those things that I just described, it leads to better outcomes for people and the best health that hopefully we can continue to provide throughout the Durham region. This mission statement and the values that we have for Lakeridge Health, we're going to continue with this statement. We're in the midst of the next strategic planning cycle, but we believe that this is so relevant even today that we're going to carry it into our next 5-year cycle. What we are going to do is look at the priorities that will fall under this that will be slightly different, and I'm going to share some of that with you. But this statement is going to be a guiding light for us for several more years. And this is a picture of the Durham region and the area that we support. Sometimes people say, well, where's Uxbridge in that? Uxbridge falls within Oak Valley, and that would be one of the only organizations that don't fall within this Durham catchment. And I've talked about this before in terms of we have to be ready for the future. Our population is expected to double in size. And that doubling in size is really important because it isn't just more people. The demographics of what's going to happen in our region is going to change as well. We're going to have an aging population, and the growth is going to come from immigration. It's going to come from people moving to Canada, immigrants to Canada, newcomers to Canada. And how we respond as a health system needs to change. We need to make sure that we break down all of the barriers that sometimes exist in terms of health inequities. And this is our commitment to the region of Durham as well. This is an exciting slide, and I think you were with us that day, MPP Co. Wow, and when I say so many people work tirelessly on our behalf, this is it. On August the 1st, we saw the biggest announcement for Lakeridge Health in the Durham region. We received a $10 million planning grant to move forward to start to address some of those growing needs in our community. We got recommitment to move forward with our Bowmanville Hospital redevelopment, which is in phase 2, and that hospital is going to double in size. We received approval in a planning grant to start to think about a new hospital in Whitby. We received planning dollars to look at a complex continuing care home in Pickering. We received dollars to look at advanced services for both Oshawa and Ajax. So really, it was the government signaling to us that that mission that we're on around building this integrated care system was supported in terms of the planning dollars that we had received, and just very grateful for so many levels of government that have helped us make this a reality. So the other thing I want to talk about is some of the challenges, though, and tonight I know that there's Queen's University here as well as others in our Durham OHT that really is trying to address this issue. There are many people in Ontario who don't have access to primary care or primary medicine. Durham, they estimate somewhere around 80,000. we're absolutely committed to trying to make sure that every single person who lives in our region is connected to primary care. And so it might not be directly with Lakeridge Health, but we want to make sure that we're good partners and that we make those connections, and we absolutely support everything that we can to make people want to move here, because when you move, you're going to get connected to primary care, and ultimately that's our goal at Lakeridge as well. We're really proud. We're going to enter in September our 3rd year of our partnership with Queen's University. So people often talk about huge, big, wicked problems, and that access to primary care is one of them. We started the first of its kind in Canada, a medical education program to train family doctors. It doesn't exist anywhere else. In September, we'll have actually 60 medical students that will be connected to Lakeridge Health. They'll be throughout the Durham region. They'll be training and learning and hopefully stay, because what we know is that this portion of people's lives when they're young and they're in their training and education, if they get connected with the community during this period, they have a tendency to stay. So if you hold any kind of connection to people, please start talking about how great Durham is, because the more we talk about it, the more we're going to be successful in this piece. The other thing we need to lean into is technology. And wow, don't we have technology at our doorstep in Durham? We have Ontario Tech, we have Durham College, we have Trent University, we have Queen's University, but we really wanted to lean into our partnership with Ontario Tech. And so we signed a formal MOU called PATH, which is Partnership for Advancing Technology in Healthcare. Ontario Tech is an untapped potential for us. They have over 5,000 engineering students who are trying to solve real-world problems throughout their training and education. We want to give them those problems, and recently we did actually in a Catalyst Challenge, and so we're really, excited about what this partnership can bring and how we can think about maybe changing and doing things slightly different. The other thing I just wanted to show you is some slides around some advancing procedures that we're doing. So we saw the first installation of a CAT scan in Port Perry. We saw a PET CT scan at our Oshawa location. And what I would say is prior to that, there were many people in Durham Region that were leaving every day for that service and that specialized diagnostic test for cancer. There was no option besides Toronto and Ottawa. And this year we saw that installation in Oshawa. And then the other thing we started was robotic surgery. And I know that there's a surgeon here tonight that we're very proud of, who will probably talk more about that. But I can tell you one of the proudest moments I had, not only as the CEO for Lakeridge, but to walk into the OR and the training room to be filled with women. No offense to the men in the audience, but women, a woman surgeon, a woman anesthesiologist, and all the support staff. And it was just so inspiring to think about what we were doing as an organization, and we're so proud of the people that work there. I mentioned mental health and addictions, and so one of the things that we did was we have a central connect where one number, one phone call connects you with a system that we help you navigate. We know it's challenging, we know we're big and complex, and just really proud of this work, and it's going to continue to foster as we move forward thinking about central intake and wait list and how we can improve our system. The other thing that I talked about was just the changing demographics for us as a region. We launched a 3-year plan for inclusion, diversity, equity, and anti-racism. Our 1-year report is available on our website. This plan really talks about what we need to do as an organization to be responsive to those 9,000 people that work in our organization. I say we're a community unto ourselves. And also the people that live and work in Durham Region, in terms of you need to feel that when you show up at Lakeridge Health, you're going to be cared for appropriately. We're going to break down as many barriers as we can, and that you feel a sense of belonging. And this is just another slide. We sometimes get dressed up and celebrate with our colleagues as well. And so looking ahead, so what I said is we have capital buildings, we're going to grow, we're going to expand, we're going to move into technology. But I think the message I want to leave you with is we are absolutely committed and dedicated every single day to doing the best that we can for the entire Durham region. And we're just really proud to be your healthcare provider and to host this tonight and hopefully share more about what we do at Lakeridge Health as an organization. Some key takeaways, ultimately what we want is that nobody has to leave our region for any type of healthcare service. So when I talk about those specialized services, that's what we're going to do. The other thing is we say that we want to be the place of choice for employment and for care, not just based on geography, but based on trust and respect that you know you're going to get when you come to Lakeridge Health. And I think that's it for me.
Look at that. You finished that in 20 minutes. We are going to prepare your next assignment soon, Cindy. All right. So next, I'm super excited to introduce what we're affectionately calling the Revolving Door series. And so what this is going to be, it's an 8-part series with each presentation. It's going to be about 10 minutes long. You'll hear from professional women from all walks of life who will walk you through a women's health journey and cover important topics on women's health. So that said, I'm really excited to introduce part 1, which is all about preventative health and screenings for women. Our first 2 speakers are Kirsten Burgomaster and Dr. Lubna Termizi. Kirsten is the Regional Vice President of the Central East Regional Cancer Program at Ontario Health and the Clinical Health System Executive at Lakeridge Health. With nearly 20 years of experience in healthcare and academia, she leads cancer services across a 1.6 million person region, driving program integration and collaboration. Dr. Termizi is a family doctor since 2004 and immigrated to Canada from Pakistan at age 6. Passionate about improving care access for underserved communities, she is a primary care co-lead for Durham, Ontario Health Team, president of the Durham Medical Society, and adjunct professor at Queen's University. Please welcome Dr. Termizi and Kirsten.
Okay, great. Welcome. It is so nice to see all of you joining us this evening. What a large crowd. I want to say to the CEO, I am on call right now, so if you hear my phone, please pick it up. Okay, why don't we get started? So Dr. Termizi and I have been colleagues for quite some time, and I'm really happy to be speaking with you tonight. We'll go to the next slide. I wanted to talk just a little bit about my own personal journey, and there is a reason for that. It is all around preventative health as women, and I'll kind of walk you through this. So who am I first and foremost? I'm a mom to 4 beautiful children. I am also a daughter to an amazing mother that I lost too soon. I'm a partner to a husband. I'm a sister, and I'm a friend. Now, beyond that, I am a health system executive at Lakeridge Health, so overseeing clinical programs. And then, as mentioned, I'm also the regional vice president of the Central East Regional Cancer Program. Again, there's a reason that I'm telling you that. I had certainty about 25 years ago about what my path would be and where I would land in the future. I started at McMaster University in undergraduate kinesiology in that program. I then conducted my master's, followed by a PhD. I went to Calgary University in the Faculty of Medicine to do a clinical placement. My dream was to go to Copenhagen. And all of that was to ensure that I would become a productive academic professor in a major university within this large world 25 years ago. I also had received the Women in Science Award, 2 in Canada, and I thought, oh, wow, things can't get any better. I traveled across the province teaching young girls the importance of preventative health, about diabetes, about cardiac care. The list went on and on and on until everything became very uncertain. My mother was diagnosed with breast cancer in my 20s, and my whole world stopped. I was a new mom. You can see the picture there of just completely being scared, terrified. What does a new mom mean? My mom in this picture is to the bottom left, and that's my little guy. And then I'm at the back with my sister's little girl. Born within 2 weeks apart, and Heidi and I, my sister, we absolutely crumbled when we received the news. My academic path became very uncertain. Hospital leadership became my calling. I knew I had to come home in those last days to be with my mom. I initially started as frontline at the McMaster University Medical Center. I then took a leadership role at the Rouge Valley Health System. And then I went to Lakeridge Health, and the rest is history. I then started to just continue in positions at Lakeridge. But the one thing that I will never forget is in those scary moments when my mom had her very first chemotherapy treatment, and my sister and I were shaking at the knees with babies in our arms. I thought, wow. I looked around and I said, Mom, one day I am going to oversee this cancer program. I promise you, I don't know how, but I'm going to work really hard to do that. She passed shortly thereafter, but I have to believe she's looking down and knows that I'm now overseeing the regional cancer program. My eyes just spotted my sister. So, why am I saying this? Preventative health is so important to us as women. And so you have to take those proactive measures. We have lots of information on healthy lifestyles. There's booths here today that are talking about that. We have massive provincial screening programs. Had my mom underwent cancer screening through the Ontario Breast Cancer Screening Program, the OBSP, she would be here with us today. We also have a huge focus on population health. So we'll go to the next slide, and then I'm going to hand over to Dr. Termesi. Population health is really an approach where we are trying to improve the entire health of a given population and really focus on decreasing health inequities among population groups. And this is what Cindy spoke about. We know as an organization, we have to understand the communities and the people that we serve, and then we have to respond to the disparities to ensure best health outcomes. Population health is influenced by many things. A lot of people will say, well, really, it's just about my health and my genetics. It's not. It goes beyond that. Pop health is influenced by income, by social status, by education, where you live, those who maybe don't have access to housing. These are all things that can significantly impact the overall health of a population, and it's far beyond just genetic makeup. Thank you for listening to my story. I'm so appreciative you're here. I'm going to hand over to Dr. Termesi.
Hi, everyone. I'm going to try my best to stay within this 6-minute window, but I'm going to start with a quote. The quote is from Martin Luther King. Injustice anywhere is a threat to justice everywhere. And Dr. Jane Philpott, our new primary care branch lead for the province, actually aligned this with healthcare. So what she said was ill health anywhere is a threat to wellness everywhere. And it really ties in with what you're saying, Kristen. Population health means really how are we all doing as a community? As you've heard, I'm a primary care physician or a family doctor in Pickering. I've been there for 20 years proudly, just love my patients. I'm also one of the primary care co-leads for the Durham, Ontario Health Team. Now, honestly, I have to spend a little bit of time just thanking Cindy. What you said right now, Cindy, with all of the things Lakeridge is doing, I would have to say I am so pleased to be here as a primary care provider because everyone you see back there, that is the community. And honestly, what the Durham OHT or Ontario Health Team is, a collaborative that brings the community together, but we would not be what we are if we didn't have our strong acute care partners. With that, basically what I wanna say is, I think I want you guys to think about what is primary care today. Yesterday was something very different. As Kristen told you about her family story, I came as an immigrant when I was 6 years old from Pakistan. And then unfortunately, my dad was an undiagnosed diabetic with heart disease. and passed away actually younger than I am today. So when we think about all of the changes in the last few decades, what we have to say is primary care is your first point of entry. It's unfortunate that in the Durham region, we have 80,000 patients that don't have a primary care provider, and it can be a physician or it can be a nurse practitioner, but it is that regular provider that you call home. I would probably say when we think about screening, I want you guys to think about yourselves, but think about your neighbors, think about your family. There's the cancer screening program. So mammograms, for example, we're here for women's health, have been now, the age has gone down to 40 plus, right? So if you know someone who's over 40 who hasn't done their screening, pull them in. It is a life or death decision for some people. Colon cancer screening, 50 and up, right? I know it's an annoying little kit, but it comes in the mail, really easy to do, and there's an expiry date on it. Now, one of the things I do want to focus on is beyond women's health. When we talk about colon cancer screening, mammograms, there's always also, the screening that is not just a cancer screening, the chronic disease screening. When you look around, look at the diversity, look at the beauty of the diversity. So many things have changed over what I would say when I started 20 years ago and what I would say today. One of the key things is, honestly, like as primary care providers, we need to look beyond what these screening guidelines are. For example, Durham Community Health Center has the Black Health Strategy. Why are they doing that? Because there's certain things that are higher risk in the Black community. There's diabetes in the South Asian community. Why should we be looking, not at a certain age or a certain risk factor, but really saying, can we hone in on what are those nuances for that certain population? And then there's all of the different First Nations communities. So I want everyone to think about primary care still as your first place to go. But I would definitely also say that if you don't have a place to go, in Durham Region, just like Cindy said, there is lots and lots of great screening programs that are live. There's our local urgent care clinics that are now comprehensive urgent care clinics. There's also something we just launched in partnership with the OHT called the iCare Virtual. If you're unattached or don't have a regular provider, it's icarevirtual.com. Go on the website, register, and we're trying our best to start working on really getting you that all of the screening and preventative care, but then connect you to your local sort of partners once there's new teams that are opening up. I think I would probably say to everyone here today, I want to just look at my time. I'm still good, so I can keep going for a second. What I was going to say is, circle back to all of those booths. It's so important what Lakeridge has done today. I think it's really important to learn about all of the resources. Public Health, for example, has the pop-up PAP clinic for those that don't have a family doctor or a primary care provider. We mentioned the CHC. One thing I did want to focus on is there's in Durham Region, as partnerships in the community and with Lakeridge, there's a lot of really unique programs that we're doing that don't exist anywhere else. And honestly, I would say the community care paramedic program with community care nursing, what we're doing is we're partnering with primary care. So if there is any homebound seniors that or someone with a disability, how are we going to reach them? So I think one of the key things is we're trying to find pathways that other regions honestly are just getting to. And part of the reason we can accomplish it in Durham Region is because we're working together. So I'm just gonna sign off with that. Honestly, I'm so appreciative to Nadia, Cindy, the whole Lakeridge team, but also all the community health partners that are here for you guys. Reach out to us. You can reach out to us through the Durham Ontario Health team as well if you have any questions about any of the programs within the region. Thank you.
Thank you for that. I think this presentation sets us up really well for the next segment. So next I would like to introduce you to Tabitha Carroll, who we also call Tab. and Dr. Julianne Francis, who will present on hormones and menstrual cycle. Tabitha is a clinical health system executive at Lakeridge Health who oversees surgery, women's and children's health, ambulatory care, and more. With over a decade of leadership experience, she previously led surgery and earned a National Surgical Quality Improvement Award. She holds advanced degrees in nursing and health management. Dr. Francis, here, now you're going to know that I'm not a clinical health expert here, but I'm going to try. Dr. Francis is a gynecologic oncologist with over 15 years of experience. She began her academic career at Harvard and Yale, later completing her residency at McMaster University and fellowship at the University of Western Ontario. Dr. Francis namely founded the gynecologic oncology program at Lakeridge Health Durham Regional Cancer Center. Let's welcome Tab and Dr. Francis.
I want to say happy St. Paddy's Day for all of those who celebrate and all the green that are out there. I'm from Irish descent, and on the weekend I spent it at a local Irish concert, and they do skits there. And one of the skits, they had an obstetrician doing an interview for a session because the community's had so many babies born. And they asked the obstetrician in the skit, is having a baby painful? And the obstetrician said, yes, absolutely painful. It's so painful, actually, that women might understand what it's like for a man to have a cold after they've had a baby. Anyways, all joking aside, one thing that we have learned over the years is that women do actually experience healthcare different than men. And when we look at over the historically, research has been mostly done into male healthcare. And how men experience illness in those pieces. And women sometimes it's different. And Kirsten shared her story about her family. I'll share mine. My mother at 66 passed away from an MI, heart attack. And women's heart attacks are very different than men's heart attacks and sometimes how they present. But we've all been taught that chest pain across your chest and down your arm. And with women, quite often, it's very different. And we haven't really been taught those signs and symptoms the same. But research and women in healthcare have actually done this type of advocacy that we actually do this research, and we actually now know that women present differently. And this is really the importance of these kind of sessions, is to really to know that there are different things that we need to learn about our health and how to manage it going forward. So much like Kirsten, I very much, since my experience with my family, had a desire to advocate for women's health. So I would ask you, how many people out here, if you could put up your hand and keep it up, have had a female member of your family that has been had the challenge of heart or stroke issues? Great. And then how many people would also say that they've had a female member of their family have a fractured hip or osteoporosis? Okay. And then how many people might have a female member of their family who struggled with mental health? Great. So I just came up with 3 different things that women experience that have nothing to do with our reproductive organs and our and those pieces, but again, that we really experience every day. But maybe we don't, as we talk about taboos, things that we're not allowed to talk about every day that are different that our women go through. So I think it's really important that we have days like today where we express the needs here and we advocate for our learnings. I'm Tab Carroll, and I am a health system executive clinical, like they indicated. I am responsible for areas in the hospital: emergency, surgical, critical care, medicine, women and children, and flow. And so in that, I have a broad team of experts, female and male. And I would say that we all see the importance and the advocacy that we have to keep that equity piece in our thoughts as we build our programs, so that it's not just the women's program that's responsible for all the care of women, but every one of my programs has an accountability for the care of women in those areas. And so I have to say we're in an excellent spot at Lakeridge Health right now, and I'm so proud to work at Lakeridge Health right now, because we are at the start of a strategic plan where we have the opportunity to rethink how we're doing things with the support of our local politicians, with the government, with our community partners, with our patient advisors, we have the opportunity to sit down and rethink how we do things in each program. And with our master planning grant and with the opportunities of new buildings coming and Bowmanville being twice the size of what it is now, we have the opportunity to rethink how to provide our services. How do we put female equity into all of our programs, not just women's health? And so, like I say, I want to say thank you again to all those who are contributing to this new culture of ensuring that we meet all of our community's needs. So in saying that, I want to let Julianne have the conversation to the topic that was really here, and I just went off on my own. But I really do appreciate all of you coming, showing your support for women's health, and taking the opportunity to learn how to make sure that you're looking after yourself so your families can have you for a very long time. Thanks.
I will just mention that for those of us who are vertically challenged, those chairs are really tall. My name is Julianne Francis. I'm a gynecologic oncologist. That was an excellent execution, by the way. Very well done. I've been at Lakeridge since 2009, actually, when we initially started coming from Kingston to support the Durham community. And in 2018, the community had expanded so much, it needed its own gyne-oncology program, which is what brought me to Lakeridge. I was going to present some slides today, but honestly, I thought it was going to be me and like 4 or 5 people in a room. I was mistaken, and realized that many of the slides that I was going to show might be something of a copyright violation. So I'm going to just speak to the subject here today. Now, it is really difficult to summarize the menstrual cycle or what goes on in terms of hormones in the female body in 5 minutes or less when most of the steps that I'm describing is a subspecialty of its own. But I will try to speak to it a little bit just so that we can get a general sense. And then I hope if people have questions afterwards that they feel free to reach out to myself or to one of my colleagues to get more information. Now, what many people don't realize is that your peak number of eggs that you have as a woman occurs, well, actually, I'll put the question out there. Does anyone know? No cheating gynecologist. I see I have my boss over here. But does anyone know? In the back over there. Inside the womb, exactly. Is that what you said? Yeah, very good. I'm impressed. Okay. So when you're about 20 weeks of gestation, you have the most eggs you're ever going to have. It's 6 or 7 million. And as many of us, those of us who are women can understand, things just start to go downhill from there. When you're born, you're already down to 1 or 2 million. And by the time you get to be at puberty or at the time of your reproductive life, you're down to a few thousands of eggs. So really only 300 to 500 of those get released during your reproductive life. So of the millions that you started out with, only a few are working for you. So that whole idea of what happens with that egg is embryology. Now, in order to even reach puberty, and this is where I was going to have the illegal slide and slight movie clip about the movie Turning Red, which I thought was going to be really great. When we reach puberty, that is when we start having the sort of symphony of hormones, really. There are so many of them that contribute to what goes on with a menstrual cycle. But I always like to tell my medical students there's a couple of key ones. So the ones that you care about most are estrogen and progesterone. And I tell all my medical students that estrogen makes the grass grow and progesterone mows the lawn. And this is where I had the illegal movie clip with SB mowing the lawn, which I thought would be really cute. Yes, I like to watch people mow lawns in my spare time. We all have hobbies. And so the balance between these two hormones is really what causes you to have your menstrual cycle every month. The first half of this is called the follicular phase, and this is more the estrogen dominant phase. And this is when we're usually more energetic and in a better mood, and things are looking pretty good. And then around the middle of this time, around day 14 or so, your partner starts being a lot more interesting to you. For medical reasons. And at that time, the balance between LH and FSH, which are a couple of other hormones, cause the egg to be released. And after that, you're in the progesterone phase, at which point your partner might inform you that your mood has changed. And that there may be a few different emotions that occur, and that takes the second half. And if there is implantation or successful egg, then you will continue on in a pregnancy, and if there is not, you will enter your menstrual cycle, and this repeats again and again until you get to my second talk, which is the one that I'm really relating to right now. So the menstrual cycle is very important because it is a vital sign of women's health. And I think this is the moment where I want to take a little bit of time to talk about advocacy, because even though I'm sure most of the women, if not all in this room, have had a menstrual cycle at some time in their life, nobody really talks to us, I think, enough about what can go wrong with it. So we're learning so much more now about undiagnosed hematologic diseases where people bleed excessively and they don't know that they're bleeding excessively, because we never talk about how much a woman should be bleeding during her menstrual cycle. How many days should she be bleeding? How many pads should she be filling? Until very recently, all of the data we had about how much a woman should be bleeding was based on menstrual pads that were designed in 1969. If anybody in this room has ever used one of those, you'll appreciate how much more absorbent a modern tampon or pad would be in contrast. So the amount of bleeding that we would be telling people that would be normal was actually in many cases not normal. Nobody talks that much about how much pain you should have during a menstrual cycle. You know, there is some pain, there's not some pain. People know very little about endometriosis or what that could mean and how debilitating these kinds of pains can be. So I think that the place where we are now, where we have so many female physicians and researchers and people interested in women's health, male or female, doesn't matter who you are, just interested in women's health. And the types of things that we are learning are really going to change what the future looks like for the next generation and the one after that. So I would say that the future is bright. Thank you so much.
So I think I found out that my grass is being mowed right now, so that's a good thing. So the next part is number 3, and it's on fertility. Oh, there you go. So I'm going to introduce, we had the pleasure to introduce two of our key presenters for this topic, Dr. Melanie Campbell and Dr. Selena Kanji. Dr. Campbell is a founding physician at Dream Fertility and has practiced obstetrics and gynecology since 2014. She trained at the University of Toronto, earning a Master of Science and researching HIV transmission prevention in South Africa. After joining Lakeridge Health, Oshawa in 2015, she opened Dream Fertility in 2021, specializing in infertility. Dr. Kanji is a reproductive endocrinologist and infertility specialist who joined Dream Fertility in November 2022. She completed her obstetrics and gynecology training at the University of Ottawa and a fellowship in reproductive endocrinology and infertility at the University of Toronto. She also works at Markham Fertility Center, and her focus is on fertility medicine and creating personalized treatment plans. Welcome, Dr. Campbell and Dr. Kanji.
So we're going to be quite practical and just talk about some basic concepts of fertility and infertility and what to expect if you need to see a fertility specialist and things like that.
Yeah, so the definition of infertility is trying to conceive for a year with no pregnancy. Infertility is really prevalent in Canada and affects about 1 in 6 couples.
As for the causes of infertility, it's a fairly even split between male factor, female factor, and then mixed causes or unexplained causes.
So ovulatory dysfunction is one of the most prevalent causes of infertility in Canada. Ovulatory dysfunction means that an egg is not being released by the ovaries every month. So typically this should happen every 28 days or so and allows the egg to be fertilized by sperm. So ovulatory dysfunction means that there's no egg that's being released, or the egg is being released irregularly. If your cycles are more than 45 days or less than 25 days, that could be a sign that the ovulation is not occurring regularly or normally. And the most common cause of ovulatory dysfunction is PCOS, or polycystic ovarian syndrome.
Other causes include male factor infertility, and that could be low numbers of sperms, in some cases no sperm at all, poorly swimming sperm, and sometimes abnormal shape of the sperm as well. And then there's also tubal factor infertility, which is where typically both tubes are blocked. That really creates such a difficult problem for egg and sperm to meet, and that can be caused by a past history of infection, by a ruptured appendix, by endometriosis, which Dr. Francis briefly mentioned. So a lot of these potential issues go hand in hand with some of the basic kind of menstrual cycle concepts and diseases that we see sometimes in women.
Unexplained infertility affects about 20% of the patients that we see. So unexplained infertility means there is an egg that's being ovulated every month, there's more than enough sperm for fertilization to be possible, and there's at least one fallopian tube open, but still no pregnancy is occurring. This is a very frustrating diagnosis for patients, and even though if we're never able to provide a diagnosis, we work together to try to help boost the chance of pregnancy every month through various different options for fertility treatment.
So these are some reasons why you may want to visit a fertility specialist. So in women under age 35, if you've been trying to conceive with regular cycles for a year, if you're over 35, we recommend starting to see us if it's been 6 months. If you're having issues being able to even have intercourse at all because it's too painful, or because of erectile dysfunction, or because of other factors related to that, that would be another reason. If the periods are irregular, then you should really start to see a fertility specialist sooner. So as Dr. Kanji mentioned, usually up to 35-day cycles. If they're typically much longer than that, that would be a reason to see a fertility specialist and might be an indication that there isn't a regular ovulation. And then for people who would like to build their families with either donor sperm, donor egg, or using a gestational carrier, those are also things that we are well equipped and very happy to help you with. And we even have a whole team that works just with donor and surrogacy to help provide education and connect patients with the appropriate resources to pursue those options. Recurrent pregnancy loss would be another issue, and that's typically defined as at least 2 miscarriages, but some definitions will refer to more like 3 miscarriages, but either way, 2 or 3 miscarriages would be significant and something that we'd be happy to see you about. And then finally, if you're interested in fertility preservation, and I think, again, a testament to a lot of education that has gone on generally, we are seeing a lot more women take control of their fertility, and knowing that with much longer time that women tend to spend educating themselves, preparing themselves for their career, focusing on their career, it's pretty common that people may not be ready or at a point to start a family until they are over 35, or in some cases even beyond that. And I remember in medical school, if you trained in medicine, you're really lucky to see the chart like regularly in your med school classes showing, decreasing fertility, increased risk of miscarriage, and essentially the decreasing fertility curve goes up and starts to peak more sharply at age 35, and then increased rate of miscarriage is similar and starts to kind of go up more sharply once women are over 35. So I think for some of us who had that information because we did medical training, that was helpful, and certainly that it is front of mind when you're still pursuing your training. But I'm happy to see that I think information is becoming more broadly available for women who may want to do that, and it's actually quite an easy process, which I think we're going to talk a bit about that at the end. Mm-hmm. Yeah.
it's not scary to come see us, even if it's just to ask us some questions about your fertility or preserving your fertility. Generally, we'll take your history, and then after that first visit, you can do some tests if you wish. The vast majority of the tests that are ordered by a fertility clinic are OHIP covered. So the tests that we recommend for patients presenting with infertility would be a sperm test, hormonal blood work, and 2 ultrasounds for the female patient. So the ultrasounds, one would be an antral follicle count. That would give us a sense of what your egg count looks like now. And the second ultrasound is a saline sonohysterogram. So that's an ultrasound where a small amount of saline is placed into the uterus, and then an ultrasound is performed so that we can see the saline flow through your fallopian tubes. All of these tests can now be done locally in Durham Region. The vast majority are OHIP covered. All can be OHIP covered if you were just looking at the basic set of tests, and usually takes not too much time at all. We'll also provide informational material on any kind of treatment that you might be interested in, whether it's egg freezing or building your family with eggs, or with donor eggs or donor sperm. And we also can have a lot of good connections where we can connect patients without any charge to them with a donor coordinator, a surrogacy coordinator, a genetics counselor, or other healthcare professionals that might be of service to them.
So just to briefly talk about optimizing natural fertility, if you are trying to get pregnant, certainly I'll maybe skip to the lifestyle part first. I think lifestyle is a huge factor, both for the person providing the sperm and the person providing the egg. So avoiding smoking, avoiding excessive alcohol, avoiding recreational drug use, getting regular exercise, having ways to manage stress, trying to get regular and a healthy amount of sleep. All of these things play a huge role in contributing to the health of egg and sperm. So I think that is something really not to be downplayed. In terms of like how to best time intercourse, as we mentioned, a typical menstrual cycle is about 28 days. Typically, as Dr. Francis was referring to, there's 2 phases of the menstrual cycle, follicular phase and the luteal phase. And if you know you have a regular cycle, without really doing any fancy tracking or testing, you can kind of just back count 14 days. So if your cycles are 28 days, approximately day 14 is probably when you're ovulating. If your cycles are 30 days, then approximately day 16 would be roughly when you're ovulating. And it's around that time that you want to have intercourse. And you know, lots of people have lots of questions about how much intercourse to have. Is it too much? Is it too often? I mean, ultimately, if the sperm is going to the place that we want it to go to, too much is not an issue, but sometimes when people have been trying for a long time, it can become tiresome in that way. And so the best days would be the day just prior to ovulation and the day of ovulation. And that can also easily be tracked with just urine ovulation test strips, which are easy to find for quite affordable time or quite affordable prices. And then things to avoid, really, that just goes with a lot of the lifestyle factors that I mentioned.
Okay, so we just wanted to also briefly mention egg freezing. So egg freezing is a way to help preserve fertility, but it's not a guarantee. So I generally tell patients that the best time to start trying to conceiving is as soon as you're ready, but if now's not the right time, egg freezing is an option for some patients. Egg freezing on average in Ontario costs around $8,000. One misconception is that egg freezing takes an extremely long period of time to do, or it's a really big commitment. It's 2 weeks, 2 weeks of daily hormone injections. During that time period, most people continue to live their daily lives. They go to work, they do everything that they normally do. The only day that you have to miss off work is the one day that you come in for the egg retrieval, because that's the day you'll be sedated, having your procedure, and we don't want you making any important business or life decisions at that point. Besides that actual day, it's usually like a minimal impact in terms of time. The important thing to know about egg freezing is that only about 15% of people who have frozen their eggs in the past have actually come to use those eggs. And it's really because egg freezing is usually someone's plan B or plan C. But still, when we look at regret and egg freezing, no one has regret from doing the egg freezing, but when we see patients presenting with infertility at an older age, they sometimes feel regret that they didn't do egg freezing. So if you want to learn if this is right for you or if it's an option for you, the ideal age to do egg freezing is under 35 years old, because that's when your egg quality is the best. but there's no bad time to come and meet with Dr. Campbell and I and have a discussion about it and see if it's right for you. I notice we're out of time, but I just wanted to say one other thing, that we were very honored to be invited to speak here today because we're really passionate about bringing good health care to Durham Region. I live here, we work here, and I brought my kids, Adam and Noah. They're over there too. Okay. Hi. Okay. Thank you very much.
Thank you.
Thank you for that. So up next, we have part 4, and this is on antepartum and postpartum, which will be presented by Dr. Tashambe Mutunji. Dr. Mutunji is an obstetrician and gynecologist in Durham Region, originally from Uganda and raised in Toronto. With a strong interest in global health, she completed a certificate in global health education at the University of Toronto. She focuses on reducing health disparities in Black and immigrant populations and increasing Black representation in medicine. Dr. Mutunji? Oh, there you go.
Hi, good evening, everybody. I'm so happy to see this crowd here today. I think this is an amazing event, and hopefully I can give a little bit of knowledge or shine some new facts on a few gems related to antepartum and postpartum care. So when I tried to think about how to present today, what I did was I kind of picked up on some things that sometimes when patients come into my office, some new information that I give them, maybe some new pearls that have come out, and things that could hopefully help anyone who's about to be on this journey or know somebody who is going to embark on having a baby. Perfect, thank you. So one of the first questions I typically get asked, actually a lot of times by friends and other people I meet in the community, is when I have a baby, what are my options for who will take care of me? So it's interesting that I think a lot of people don't know that you do have 3 different options, but that these options are typically mutually exclusive. So you have an obstetrician, that would be like myself, somebody who's gone through obstetrical training and gone through a residency and they are an MD. Then you have a family practice obstetrics doctor. So they would be kind of like your family doctor that takes extra training that can also deliver babies. And they do come to L&D and they have a whole practice that works side by side to obstetrics. Then there's the practice of midwifery. And unfortunately, I was hoping to have a midwife colleague up here with me today, which would have been great because the way in which they practice is quite different from obstetrics and family practice obstetrics. I'm a midwife, and I think the big difference, and again, it would be nice to have one of them here to say so, is that the midwife actually sees you through from the care of the time when you're doing antepartum care to the care of your baby, and will actually see you at home the next day. That's different than the other 2 practitioners. So this is also something that I think is very important for all of us to know, kind of, again, anyone who's about to embark on pregnancy. So this is the concept of baby aspirin. So I think we mostly know baby aspirin to be used for people with heart conditions. But what we actually use it for quite often in obstetrics is to help protect against something called preeclampsia. Now, preeclampsia is a condition that can happen to a lot of women. Typically, we see it peak closer to the end of your pregnancy, where it involves having high blood pressure and leaking proteins into the urine. And so it has a lot of complications that can be associated with the pregnancy, delivering the baby, a small baby, having an early baby. So something that we really tried to prevent as practitioners. So there's a few reasons why we want women to start taking baby aspirin earlier in their pregnancy to help prevent preeclampsia. And it's actually a very interesting list that when you look at it, I actually find reasons for my patients not to be put on baby aspirin versus the other way around. So if you look at something like, I don't know if you guys can see, line where it says moderate. So if you have 2 of the things under the category that says moderate, you should be on baby aspirin. So if you look at, for example, being a mother above the age of 35, and then a nulliparity means you've never had a baby. So if you've never had a baby and it's your first time and you're 36 years old, like we know a lot of women are, you should be on baby aspirin. And I think the interesting part about it is typically baby aspirin, the best time to start it is quite early in a pregnancy. So even before you get to, typically before you get to any of the practitioners I talked about, most women should be started on baby aspirin. So you'll see other things there like a family history of preeclampsia, your mother and sister. And then this is also interesting, socio-demographic characteristics. So being of an African race alone, low socioeconomic status are all reasons to be started on baby aspirin. This is another real big gem that I try to harp in my office. So this is pelvic floor physiotherapy. So this is actually a very interesting specialty or area of physiotherapy because it's a practitioner that specifically took extra training only to concentrate on the pelvic floor. And they are really, really amazing and very, very helpful practitioners. So what they'll do is they will do exercises that help with pain in pregnancy. Unfortunately, a lot of women have pelvic pain, they get sciatica, things that they can't actually take medications for. So physiotherapy is actually the only and probably the best treatment that we have for something like this. So what we do is we give a referral to women while they're still pregnant to go and see the physiotherapist. They'll also help you with kind of techniques that can help you during labor, breathing techniques, bouncing on a ball, things like that, and ways that your partner can also be involved in your pregnancy. So they're wonderful. They also protect against something called prolapse. This comes way later in the life cycle, but it literally, I don't have a nice way to define prolapse other than all of your organs fall down through the vaginal canal. It's not a wonderful thing, and it is quite common, and a lot of women don't talk about it or know about it until much later in life, and going to pelvic floor physiotherapy can actually help prevent this, as well as it can help prevent urine leakage, bladder issues. All of these things come from bearing children or several children, that this can actually be very, very preventative. Okay, so vaccinations. This is also a big topic that I talk to a lot of my patients about in the office, because this is something that can help not only moms while they're pregnant, but also newborn babies. So there's a list of vaccines that we talk about during pregnancy that are quite important. The first three, so the flu vaccine, Tdap, which protects against whooping cough. The P is the pertussis for whooping cough. And then now most recently RSV. So these vaccines can be given during pregnancy. The flu mostly to help protect mom. And I know some people choose to get a flu vaccine, sometimes they don't. But I think what a lot of women don't know is that if you get the flu when you're pregnant, it's much different than getting a flu when you're not. You can get much sicker, end up in the ICU, that kind of thing. Kind of similar concepts to COVID and being pregnant. You got it while you're pregnant, you get much sicker. So we always encourage women to get the flu vaccine. Pertussis helps to protect newborn babies against whooping cough, which is really bad for a really small neonate and can really damage their lungs. So we encourage patients to get that. And then RSV is a newer vaccine, so it can be given to both mom and baby, but we talk about it during pregnancy because you have the option to get it at that time. The last two, my baby is also here. The last two are chicken pox and the rubella vaccine. So we screen women in pregnancy for these two vaccines in hopes that if they find that they're not immune to these two things, that they will get the vaccines after they deliver. So it's just kind of a point in which a lot of healthy women wouldn't go through the medical system until they're pregnant. So it was decided that this is a good time to find out if you're immune to those two things. So this is just my slide on postpartum care. So I think what I wanted to add or say about postpartum care is that postpartum is a very difficult period for a lot of women, and I think it's a period that we don't talk about probably enough, and the things that can happen during that time. Now, a lot of women have a lot of family support. Some people have family members that come move in with them. They have local family, but not everybody has that. So I just wanted to talk about some of the other options that women have. So I talked about the midwife. Typically the midwife, and I believe I am correct, will come to your home the day after the baby is born to kind of help support you in that way, give you some pointers, help with breastfeeding, so that care is there. A postpartum doula. So a doula is something also that's a fairly new area in medicine. And so what a doula is it's actually defined as a labor support person. So a doula doesn't actually have any medical care related to the pregnancy, so they won't check your cervix, they won't labor with you at home like a midwife will, but what they do is add to the support network while you're laboring. It's actually interesting because having a doula or a support person at labor is actually a very good predictor for women having a natural or a vaginal delivery, because they have that extra person to support. So they're a great person to have on board, part of your team. Not easy to find, but they do exist and they're very helpful. A night nurse, so if you have the ability to hire one, that's another thing that helps a lot of moms. And then Healthy Mothers, Healthy Babies is a great resource that we have in Durham, where they'll actually come and support, and usually they're kind of flagged, or patients are flagged from their actual obstetrician or maybe at the hospital or by social work, where they'll show up at the mother's house and help with different things like, again, breastfeeding, young moms, maybe people who don't have as much family support, and they'll come and help you there. And then a lactation consultant. So this is also a very, very excellent resource that we actually have at Lakeridge Health, and we have a very, very great group of lactation consultants. So I think we have maybe at least 2 at each site for where we have labor and deliveries in Durham. And what they'll do is they'll help you if the baby's struggling with latching or milk letdown. And they're great because sometimes some of the stuff that happens with breastfeeding doesn't happen in the hospital. It happens when you get home. So they're actually great and helpful there. And then mental health. So that's another huge one that we tend to kind of leave to the wayside, unfortunately, a lot in postpartum. We know that probably 90% of moms will struggle in that first 4 to 6 weeks, but it's sometimes some women need extra help afterwards. And so, you have counselors, you have networks that provide free mental health support, and then we do have psychiatry that sometimes specializes in perinatal health. So we always advertise or ask our patients not to stay at home and let things simmer because it can become very difficult with sleep deprivation, newborn baby, and other things that you have to manage. I think that's my last slide. That's it.
All right, so up next, like I said, is part 5, which is on perimenopause and menopause. And I'd like to welcome back on stage Dr. Julianne Francis, who will be presenting on this topic.
I'm going to describe something that I saw a couple of decades, maybe 3 decades ago. I'm watching a commercial at home, at my parents' home, and I see the most bizarre thing. It's the dead of winter. This is why I can't show you the slides, by the way, copyright. It's the dead of winter. A woman walks outside. She is wearing shorts. She walks over to a piece of equipment and yanks the lid off of it, and then walks back into the house, and you see it fire up, and you're like, I think that's her air conditioner. And she closes the back door of the screen, and then the next thing that comes up, and menopause consultations available at Shoppers Drug Mart. And at the time, it really made an impression. I was like, why would anybody turn on their air conditioning in the dead of winter? Can relate, okay? I now understand very fully. So this talk, I feel like is a little bit closer to home. So I would say that as a person, one of the words that might describe me would be resilient. I have been trained in a time when there were no work hour restrictions for doctors. So as a young physician, I had worked weeks that had alternating 132-hour weeks with 120-hour weeks. There are 168 hours in a week, in case you were wondering. Okay? I have had my thumb broken by a piece of surgical steel as a disciplinary action during a surgery and finished the case and did not cry. However, when my daughter was 2 weeks old, I did a presentation at a meeting not dissimilar to this. When she was 6 weeks old, I ran an international meeting. When my son was 1 week old, I took my son, who was 1 week old, on a plane with my daughter, who was 20 months old, so that I could present at a meeting. So prior to this, I would have said, what have you got? Bring it on. And 3 months into menopause, I was like, where are the drugs? Somebody give me some soon. So it is like a change of life. I think that is a fair way to describe it. Now, one of the things I'm sort of sorry I can't show you is that if you're a person like me, you have friends that are not dissimilar from you. So I shared in a friend chat, hey, I've calculated when all my cycles would be as I'm going into menopause, and they all immediately sent me the graphs of their own cycles too. So what you will see is that for those of you who have not yet transitioned, one of the things that people don't tell you is that there is perimenopause and then there is menopause. You don't keep having a regular cycle and then one day snap, you don't have them anymore. There is a period of time where you have cycles that become increasingly irregular, often very heavy, a lot of mood changes, a lot of hormonal changes, and just generally a lot of symptoms. And one of those symptoms is that it can be associated with very heavy bleeding. Now, if you take anything away from this today, if you are having very irregular, very heavy bleeding and you're around the time of menopause, you do want to share this with your medical providers and not just like walk away from it, because one of the things, and I am an oncologist, that we do see are endometrial cancers in women in this age group. So if the bleeding is really heavy, you do want somebody to check it out, do some investigations, and make sure that there's nothing going on that you don't need to be concerned about. As you enter into menopause, there's a wide variety of symptoms that people often find debilitating. And similarly, this is also a really good time to have a conversation with your healthcare provider about whether or not you want to have any type of hormone replacement. Hormone replacement got a very bad rap, I would say maybe about 20 years ago, because prior to that, they gave it to everybody. And then they did a study that said it is terrible, and they took it away from everybody. And now I would say we've reached something called equipoise. And the reason that we did not know what was going on was because the science was not caught up to where the studies were. So the reason that the first group of women did really well when we looked at hormones was because they were very young. They did a nurses study, they were mostly in their 40s, and all of those women did brilliantly. They then did a study on women where the average age was 67, and what we learned is that if you give hormones to a 67-year-old, all those plaques that she has now developed in her vessels because she had no hormones will break off and cause her to have a heart attack or a stroke. So you have a narrow window of time to decide which way you're going with this. If you want to try hormones, you need to kind of do it around the time. Because if you get to a certain number of years past menopause, you then cannot go back and decide that you'd like to be on hormones. Now, it's not as simple as what I'm saying, because there's so many issues that go into a personal decision. It's like, what's your personal history? And I will even tell you that when this happened to me, I have a lot of friends. I can phone a friend who is a gynecologist, and I was like, please just give me drugs. I cannot do this. And what you'll learn is you have friends and you think they're your friends, but if you you think they're your friends, but if you start asking them for like medical favors, they like to pretend that they are a doctor now. And they will make you, even me, go and have all of the investigations required to be getting these drugs, as opposed to just writing you a script in the hall as you might like, you know? So for everyone, there are individual factors and pieces of information that you need to have that will allow you to make a good decision for yourself about whether or not you'd like to have that type of hormone management. Now, some people feel that because there is a slight risk of getting a breast cancer, and there is, and it depends on your personal history, that they prefer to use a more natural course and not have hormone management. And what I would recommend in that case is that there's a wide variety of lifestyle choices that you can make that will reduce the symptoms that are associated with it. Most of those things are what cause me to want to live life. So in my case, so you have to exercise daily, you have to give up caffeine, you cannot have alcohol, and there is no chocolate. Exactly. Exactly. However, if you are the kind of person who can step up to all of that, there are other things you can do to help you. And we do have some non-hormonal medications that we give that also help. And these are actually antidepressants. They are being given for hot flashes and other symptoms. However, we do not know how this works. I don't know if it's just like you're happy now, so the hot flashes bother you less. But it does seem to help, is what I can tell you. So I say all of that to say it is an important transition. but there are some really good things that come along with it. And I think that that has to do with the phase of life that you are in. I miss terribly not being able to bring my own babies with me to presentations like this because I'm now cringe and have aura debt, but that is okay. I am proud that my children are independent and it allows me more time to be involved in other roles, to give some of the mentorship that has been given to me. I see Dr. Ismail is here, to people who are behind me in this sequence of events. So there are some very empowering things about becoming a woman who's reached a certain age. Okay, thank you very much.
Okay, so my lawn is being mowed and I'm in perimenopause. Thank you. So next up we have healthy aging, which is part 6, and I'd like to welcome Jacqueline McLeod, who will be presenting on this topic. Jacqueline is a healthcare professional with over 20 years of experience specializing in advocating for older adults. She returned to Lakeridge Health 15 years ago and recently led the NPJ Paralysis Initiative aimed at improving patient outcomes by encouraging mobility and reducing the effects of prolonged bed rest. Welcome, Jacqueline.
I have a crumpled up lab requisition that I've been carrying in my car for about a year that I'm going to go and fill tomorrow after that talk. So thank you, Dr. Francis, for that. All right. Okay. So as was alluded to, is there a back? Am I okay with this? Okay. I never miss an opportunity to talk about an amazing initiative that Lakeridge Health has embarked on over the past year. We have, as an organization, really focused on our seniors, and we focused on getting people moving when hospitalized. And we're taking away the patient. We're stopping looking at people as admitted patients and people who are sick, and we're moving towards looking at being admitted as part of your healing journey, and that this is who you are. So if I was standing up here in a hospital gown, I don't think I'd be able to talk to you. I'm having enough time right now with the back feed. But I think I would really struggle. Part of who I am is how I present to you. So think about a time when you were in a hospital gown, whether you were an admitted patient or you were getting a test. Did you feel empowered? Did you feel like you were ready to take charge of your own care, to get up or move around? I don't think that we do. And that's what we do to our patients, our people, when they become admitted into our organization. We remove the personhood from them, and they look like everyone else. When I look out over the audience, I see a variety of different people here. And we need to empower our people to remain people when they're part of Lakeridge Health. So we've done really well in doing this initiative, and it really helps support our mobility. We've really embarked on having all of our admitted patients have 3 or more mobility events in a day. And part of that is being dressed and enabling people to do that on their own. I think that when we were talking about everything we're looking at here is really moving from sickness to health and looking at creating a culture of healing, encouraging patients to, I'm going to take a pause here and just go back to talking about what I want you as community members to do. So when you have your loved ones admitted to the hospital, bring in clothes. Encourage your loved ones to get up and get dressed and get moving, looking for loose-fitting clothes and really being part of their healing journey. Okay, so we've all seen how something as simple as mobility can have an impact on a hospital stay. It can have a powerful impact on the recovery, dignity, and mental well-being, especially as we age. But healthy aging isn't just about the body. It's also about keeping our minds sharp and resilient. That brings us to a crucial topic, which is brain health. Protecting our cognitive function is just as important as maintaining the physical mobility. So as we're talking about being perimenopausal, I think a lot of us would relate to this topic. Have you ever walked into a room and forgotten why you were there? Have you ever searched for your phone while you're holding it? Looked for your glasses while they're on their face? All these small moments of forgetfulness can feel frustrating, but they remind us the importance of caring for our minds. Every 33 seconds, someone loses their life to Alzheimer's disease. Mortality rates are climbing, and nearly 70% of those diagnosed with Alzheimer's disease are women. Dementia has now surpassed cancer as the most feared disease, and with no known cure, the concern is very, very real. But here's the good news. Research has shown that approximately 40% of worldwide dementias are linked to modifiable risk factors, things that we can control through many of our own choices. Dr. Francis touched on many of those, which perhaps we are going to take with a grain of salt, but it is important to look at our brain health and see what we can do in order to keep our brain active and engaged as we age. As women, we juggle countless responsibilities. I see you here tonight, and I love that people have brought their babies, their children. Some people brought their husbands. We have countless responsibilities, excelling at work, raising children, and caring for aging parents. But with so much on our plates, it's easy to put our own well-being last. But prioritizing our brain health is not a luxury, it's a necessity. The key lies in building a lifestyle that supports the body and the mind. Simple and consistent actions can make a difference. So if we look at the 6 pillars of brain health, we look at exercise, balanced nutrition, stress management, social connection, mental stimulation, and quality of sleep. These all play vital roles. By focusing on these 6 pillars, we can actively reduce our risk of cognitive decline and build stronger, healthier brains as we age. So let's take charge of our brain health today, because a sharp mind isn't just about memory, it's about living a full, independent, and vibrant life. So when we talk about cognitive brain health, it's not something we really think about. And so what does that mean? How do we actually exercise our brain? It's interesting because research has shown that 30% of older women actually have brain changes that are consistent with Alzheimer's disease, but they're not showing symptoms. And what is the difference between those women and the women that actually are showing the symptoms we associate with Alzheimer's disease? So forgetfulness, they're reliant on others for their day-to-day activities. And it's called cognitive reserve. So this is the brain's ability to adapt and compensate. So cognitive reserve is built through lifelong learning and mentally stimulating activities. Things like higher education, attending events such as this, challenging work, learning a new hobby, learning a new language, or even doing challenging puzzles. These aren't just hobbies that we do, they're really protective tools for our brain. So as much as we prioritize our physical health, it's very important that we challenge ourselves to keep our minds strong and resilient. So this Brain Fit app, that's Canadian made, very important, is an app designed to help women ward off dementia. This app promotes brain health by promoting daily and weekly habits like drinking water, learning a new language, or engaging in challenging activities. So healthy aging for women starts with small intentional choices, moving more, connecting more, challenging our minds, and seeking support when we need it. So as we talk about keeping our brains active, it's important to recognize the context in which many of us are trying to maintain this brain health. For a growing number of people, that is the caregiver. And as I just mentioned, many of us I see people on their phone, calling their kids at home, talking about dinner that's in the microwave, and everyone's adapted to be able to be here tonight. So you've made the first step in making a commitment to you. And it's so important that while a caregiver is caring for a loved one, they also remember to care for themselves. So in Ontario, more than 4 million people are caregivers. They're caring for a family member, a friend, a neighbor, and almost 3/4 of them are women. The average caregiver is a 49-year-old woman who works outside the home and still spends 20 extra hours providing care. While women take on this role with the best of our intentions, we often quite easily become overwhelmed and exhausted. A recent survey in Ontario alone found that 44% of caregivers were very unprepared for the demands that the caregiving would place on them in terms of professionally, emotionally, and financially. Many people don't anticipate the full impact that caregiving puts on them, that puts on their families, that takes their time financially and professionally. Women who are caregivers are more likely to experience poor health. They're more likely to report mental distress and experience severe anxiety and periods of depression. So I imagine some of you in this room can relate to these words. You're feeling the weight of caregiving right now, navigating the emotional and physical demands that come with supporting a loved one. So here on the screen is an amazing resource that we have in Ontario that really is underutilized. It's the Ontario Caregivers Association organization. So this is a 24-hour, 7-day-a-week support system for caregivers. They have helplines, peer support programs, free counseling, online learning, and guidance for navigating the healthcare system. If someone is new to caregiving or if they've been in the role for a while, they make sure that no caregiver feels alone or unsupported. So caregiving is a journey that no one should have to navigate in isolation. By seeking support, sharing the responsibilities, and utilizing available resources, we can create a stronger, healthier caregiving community, one in which both caregivers and their loved ones, I've got the time here, feel that they can survive. So again, I just want to take the time to thank you for being part of this important conversation and for committing to yourself for being here tonight. For as women, learning about what resources are available in Durham, learning what Lakeridge Health can do for you, and learning how we can grow together.
Thank you, Jacqueline. So the last two parts are on health equity, which is an important part of the work that we do here at Lakeridge Health. Part 7 in particular will focus on academic excellence and innovation. And this time we will have 4 speakers. Let's see how they do at timing. So we're going to call up Dr. Nadia Ismail, Ava Onwudegwu, Dr. Natasha Aziz, and Heather Lithgow. Dr. Ismail is the Deputy Chief of Staff and Chief of Academic Affairs and Research. She oversees quality, safety, leadership, and diversity initiatives while advancing research and medical education, including the Queen's Lakeridge Medical School launch focused on building primary care in Durham Region. Dr. Ismail received her Doctor of Medicine in Iraq and completed her residency training in anatomic pathology at Memorial University in Newfoundland. Ava is the Clinical Director for Critical Care, Trauma, Respiratory, and Women's and Children's Programs at Lakeridge Health. With a Master of Nursing, she has held leadership roles at both Lakeridge Health and Unity Health Toronto. Ava is dedicated to transformative change, focusing on creating inclusive environments, enhancing healthcare systems, and empowering healthcare professionals to deliver exceptional care. Dr. Aziz is a family physician in Newcastle and a curriculum director for the Queen's Lakeridge Health MD Family Medicine program. She specializes in women's health and helped develop the new MD program. Dr. Aziz earned her medical degree from the University of Western Ontario and completed her residency at Queen's University. Heather is the Director of Surgery at Lakeridge Health with leadership and clinical experience across surgical care. She holds a master's in nursing from Toronto Metropolitan University and a perioperative specialty certification. Heather is an active member and reviewer of the Operating Room Nurses Association of Canada National Standards Committee since 2015. Welcome, Heather, Ava, Dr. Ismail, and Dr. Aziz.
Thank you, Shara. So I'll talk about my biggest passion, which is academia and research. And I'm so privileged to also be the chief of academic research, of academic excellence and research at Lakeridge Health. I'm a huge believer in the value of academia, of knowledge, of transfer of knowledge, and at the same time of the role of research that it plays into what we really believe in, which is providing the best equitable and the best care for the communities that we serve. And I truly believe that academia, innovation, and research play a significant role in that. So when we look at Lakeridge Health, we look at it as a very important healthcare system serving the population in the Durham region. But in addition to that, if you come to Lakeridge Health, you will see the Learn Center. We have almost 3,000 students in our walls every year. We have the innovative MDFM program that Dr. Aziz will be talking about. We already have 60 students who will be coming out of this system and serving the community in the Durham region as family physicians. We have innovative partnerships with multiple organizations, including Ontario Tech, including Durham College, including Queen's University, University of Toronto, and they're all there. So what we are inviting all of you to look at is not only us as a very functioning, highly functioning healthcare system, but also a system which is embedded in academia, embedded in innovation, and also embedded in academic excellence. So you will hear from my colleagues what we have done at Lakeridge Health to serve our communities. Thank you.
Hi, everyone. So when we're talking about health equity, one of the things that is important for us to understand is that it requires everyone to have fair opportunity to achieving their best health, regardless of race, gender, socioeconomic status. And one thing we will say, just based on this panel that we have here, is that innovation in research, education, and community engagement is pivotal in addressing any disparities that do exist in achieving this. So when we say fair opportunity, sometimes the question is, how do we determine what is fair? And when we're saying fair, is it from the perspective of the healthcare providers, or is it from the perspective of the people that we're actually serving? And how do we, as healthcare providers, equip our communities, our patients, and their families to be able to engage and in determining what is fair? I'll share two examples with you. For instance, if we were to think about a newly immigrated mom coming in to Canada with 3 kids, no supports, just on her own, coming to our ED department, our youngest is sick, difficulty breathing, how do we identify what's fair to her? Or how does she know what fair opportunity is within a system that she does not know? Or when we think about a young Black or Indigenous woman who is in our healthcare system with excruciating pain, never been in our healthcare system, not knowing how to navigate it, how do we define fair opportunity for that person, or what does that experience look like for them? I think when we're looking at this, it's important that we realize that fairness, there is a requirement for us to look at our systemic situation a little different and veer from the normal paths that we've historically followed. And I say this because when we look historically at our women in our communities who have historically been, exploited or excluded from, say, research or educational opportunities, or even looking at, for instance, when you think about even our Canadian history, where we, during the 1920s to 1970s, had forced sterilization of Indigenous and Black women. These are things that have caused a lot of mistrust within our healthcare system. And so when we're thinking about this, how do we regain and build that trust within our communities? And I say, one of the things I am proud of in being a part of Lakeridge is that there has been concerted, focused effort in actually engaging our community. We see senior leaders, we see different leaders being in our community at events, at different groups to hear what our community members are saying, to bring that back. It's important that we are also thinking about how do we create groups and focus groups to engage community so that their voice is at the table. And when we look at our organization, we have committees where we have family members and patients being a part of those committees to ensure that decisions that we're making, the way we're approaching care, the policies that we're making are including those voices, because the inclusion of that is of utmost importance to us. We have our amazing medical school, and a lot of education, as Dr. Ismail said, is actually happening at Lakeridge. And so when you're looking at bringing all those pieces together, and I have to give a shout out to our amazing research department that really ensures that we are taking into account the voices of the people, the end users, that will be impacted by the research we're doing. And so I want to just stop by saying nothing for us without us should be the motto that drives any innovation that we're doing when it comes to health equity. Decisions and policies affecting women, especially women who have been disenfranchised in our healthcare system, should not be made without direct involvement and input. Representation matters. Participation and self-determination is a requirement.
Hello, thank you. I'm Dr. Natasha Aziz. I'm a family doctor in Newcastle, as it was mentioned. And I have a question to start, which is, who in this room does not have a family doctor within half-hour drive of their house? Okay, see all the hands? So this makes sense because, as Dr. Tamirzi said, there's 80,000 people in Durham Region who do not have a family doctor, and there's 2.3 million people in Ontario. So Lakeridge Health and Queen's University have partnered to try and help address this crisis in our area. And so what we are doing is we have a new medical school campus, which is located right here in Durham Region in Oshawa. And we already have 20 students a year who are training to be family doctors right here in Durham Region. So we have 2 classes who are currently in, and we're in the midst of the admission process for our 3rd class. So as of September, we'll have 60 students. So this is great news for our region because really I think it's an important part of the work that Lakeridge and Queen's University are doing to help better meet all the health needs in our population, but especially women's health needs. Now, one of the unique things about family medicine training is family doctors are not an expert in any specific area of medicine. What they're actually experts in is experts in their patients and their communities. So a family doctor training program is focused on understanding all the different conditions that affect the life cycle from, babies, adolescents, adults and older adults. And we are also one of the few doctors that you can have for decades throughout their careers and really getting to know the patient as a person and their unique health needs. Now, when it comes to women's healthcare, there are some myths that I wanted to dispel about family medicine care. Many people believe that women's health issues will automatically require the input of a specialist, or they may believe that family doctors are not trained to address women's health issues. Now, modern family medicine training programs are absolutely focused on these things. Family doctors are actually experts in the life cycle transitions. That's how we refer to it. So that includes things like what happens in your life around puberty, and the education family doctors get actually extends beyond the medical elements, but also some of these family relationship, social workplace elements that can be impacted by transitions. And I'm sure many of you in the audience know those transitions are often the points at which many health issues will emerge. So puberty, new parenthood is something we heard about today, and also the menopause transition and also aging and end of life. So definitely it is appropriate to bring any concerns to your family doctor. Another myth is that certain women's health issues specifically are too personal to bring to your family doctor. I can tell you as a family doctor, nothing is too personal. So I just want to encourage you, if you are lucky enough to have a family doctor, to please don't hesitate to bring your health concerns to them. Sometimes referrals to specialists are needed and essential, but sometimes they can be not needed, and you may be delaying your care or causing discomfort by not bringing those issues to your family doctor. And then just to wrap up, I wanted to encourage you to visit our booth. Our booth has more information about some of the equity-driven admissions initiatives that we have at Queen's. We'd love if you know anyone who would be a good candidate for our program for them to apply. We need more family doctors in our community, as you know. Thank you.
I just wanted to thank you for having me tonight. I get to talk a little bit about the application of a lot of the work that's been spoken about so far. And so I just wanted to introduce something that really has been a community initiative, and that's robotic surgery at Lakeridge Health. And so what that means is we do have a very cool technical innovation that rolled down our hallway with a huge clap in and was really supported by so many of our clinicians. That's why I have slides, because surgery is a team sport, absolutely. And so this is really to speak about some innovative technology that is absolutely earth-shattering for a community hospital. We are on the map, we are large, and this just reinforces that as well. So last 2 years ago now, April, Dr. Francis, who you heard from, who's an absolute rock star on our team, did the first robotic gynecologic oncology case at Lakeridge Health. And this is Kathy, who was our first patient here as well. And some of the things, there's no speaking notes, so I have to rely on my memory here and just sort of the teleprompter. But what this really meant in Kathy's words were, she said it was truly unbelievable to have a robot doing her surgery. And she really reflected on how she was able to go home the first day, and she noted a big difference in her experience in having this less invasive procedure versus previous operations that she'd had before. I have to give an absolute plug because we did 150% of the surgical volumes that we had planned to do in our first year of launch. So we gave the team a target and they absolutely knocked it out of the park. We didn't slow anybody down. We just kept driving towards the finish line. And that takes the whole team. So our finance partners who are here at the table, our senior team supporting that as well. Julie and I talk often, as do Chris and Tab. And our all-female gynecologic oncology, I'm trying to change your title, usually I just say our gyne oncology department, of 3 female surgeons did 40% of all robotic surgery that happened at Lakeridge in year 1. I don't think those were the 160-hour work weeks, but I'm not actually sure that we didn't rival some of those. And so I just wanted to show here, you will see there's Dr. Francis in our top shot there. I don't need to refer behind me. Dr. Elena Igwe is in the shot below her. And where I wanted to also thank our community. It's our community that made this possible. I see some of our foundation partners are here in the audience, and it takes a team fundraising across all of our hospital sites and community donors that have made donations, that have made innovations like this possible as well. And we can flick to the next slide there. So what this means for our community and patients who are diagnosed with a uterine cancer and endometrial cancer is that they no longer have to travel outside of our region. Cindy said, our vision really is to bring all of that close to home, to your own community hospital. You could go through that process with your family doctor, get referred to a local expert that's in the same Durham region here, and have your surgery. So I know we're working in our diagnostic department as well, and there's been huge innovations done there. Prior to the robot coming to Lakeridge Health, you would have had to travel to Ottawa or to Toronto to have this type of service, and you can see there on that nice, beautiful bar graph there. Our volume of population is really quite high, and we were one of those kind of to the left hospitals with a large catchment, large population to serve that didn't have a robot. We can say today that we do, and we keep all of our community members cared for at home that need that service. The reason this is a huge technical innovation is also because it reduces your length of stay. You can go home the same day. Your complications are reduced. The need for you to have a blood transfusion during your surgery is reduced, and the chance that you'll come back to the hospital and need to be admitted into an inpatient bed is also reduced. Our surgeons have also noted there are many patients that they wouldn't have been able to operate on with this minimally invasive technology in hard to reach places without this approach. So it's really been life-changing for those patients. And because this is a Women in Health event, I just wanted to say this also helps us to recruit many world-class physicians who are trained in robotic surgery to Lakeridge as well, which cannot be understated when we're growing at the rate that we are and trying to keep a high caliber of talent with us. This is my plug to say I work on the program side. I brought the org chart because we're all women actually leading the surgical program on the program side, and so I think that's novel, and that's not to say that we don't have men leading surgery at Lakeridge, because my colleagues John and John, actually I could not lead the program without them, and they're absolutely integral. But I think the message here really is there is a large place for women leading healthcare at Lakeridge, and I think that's just evidenced by this team. And that may change. This may not always be the way we have welcomed men to our team in the past, and I'm sure we will again. But these are just some of the positions that we do have that are led by women, and so I just wanted to highlight that on the last slide to round us out today. Thank you very much.
All right, full disclosure, the crying baby is my niece, so I apologize. All right, but it's a Women in Health Symposium, y'all get it. Okay, so the final part of our Revolving Doors series is also on health equity, but this time we will focus on access. And so for this, I'd like to introduce Patrina McGrath, Umwali Sauter, and Susan Byrne also. Patrina is an experienced healthcare leader with expertise in change management, quality, safety, and interprofessional practice. She is a clinical health system executive at Lakeridge Health and supports teams in inclusion, diversity, equity, accessibility, and anti-racism, which we also call IDEA, patient safety, quality, strategy, risk, and patient experience. Patrina holds degrees from the University of Saskatchewan, University of Toronto, and Fielding Graduate University. Umwali is a health leader with over 25 years of experience in health equity, policy advocacy, and community impact. Passionate about breaking barriers, she helps to build inclusive, health-promoting systems for diverse communities. As Director of Organizational Development and IDEA at Lakeridge Health, she leads cultural transformation and oversees wellness, volunteer resources, and spiritual care programs. Finally, I'd like to also welcome back Susan, who's the Crisis Intervention Counselor with Victim Services of Durham Region. Thank you.
I am going to start off. I'm Patrina. And first of all, I just want to say, I'm just so in awe of all the amazing women that work at Lakeridge Health that have spoke or are working with us at Lakeridge Health. And it just, again, really shares for me both the environment that they're creating, but also the advocacy, the push on research, and all of the things that you heard about today. And I feel really blessed to be part of this organization and be part of this team. I'm going to just say a couple words, and then I'm going to hand over to these two because I am in awe of both of them, and I learned so much in just my brief time talking with Susan, and I learned from Umwali every day in my work. I have had an incredible career, and I've been very much supported in my career by incredible women. And when I think about Lakeridge Health and I think about the Durham community that we've been talking about, I think about them as an overlapping. The Lakeridge community is part of the Durham community. The people who come to work at Lakeridge, volunteer at Lakeridge, go home to their communities, many of them in Durham. And so when I think about inclusion and equity and health, I often think about the people who come to work every day and volunteer at Lakeridge Health, and how critical it is to think about that, because the same people that work at Lakeridge Health that show up every day to provide care to this community Many of them are going through menopause. Many of them are having babies. Many of them might be dealing with mental health issues. They may go home and have to deal with domestic violence. They may be, experience trauma in their history, and they come into work every day, and there's things that happen in our environment that may impact them. So you can't have a healthy community of Durham without also thinking about the health and well-being of the people who come to work every day to give care. So it's really an important part of the work I do, the work that the team that I work with does. And I think that's something really important. If we can care for the people who work and provide care, that just translates into care for the ability to be present as a caregiver and support to the people that that come to us every day. I also just want to say I'm a mom, and I'm a mom of two incredibly independent young women, 21 and 23, and both of them either are working, one's in medical school, the other one is going to be an amazing teacher, and my second daughter has had her own health journey. She has had health conditions, she's been a patient, she's struggled with mental health, and when I think about an inclusive environment and a healthcare environment, I want to make sure that that environment is a place where they can work and thrive, and that they can be their full self. And so much of the work that we do at Lakeridge is, again, trying to create that environment, as Cindy said at the beginning, where I belong and I can be my full self, and also that all the patients and community members that come can feel like they can see themselves and that they belong when they come to get care here. And I'm going to hand over to my colleague, Amwali, to say more about that.
I was going to try and sit. It was not going to work out. So here we go. So I want to thank everybody who's shared all the expertise and thank the room for joining us today. If we could take a moment and see that actually this room would not look like this 20 years ago, 40 years ago, 60 years ago. We're standing on someone's shoulder, each one of us here. So I'm holding this space for us, for the past, and for the future generations. Loved those cries. I was like, all right, I'm doing this for you. So here's to the future generation. So I'm here to talk about IDAA. And, on a broad scale, IDAA is here to make sure that everybody who comes to get care at Lakeridge Health feels welcome, regardless of what their background is. I'm here to say that everybody who works at Lakeridge Health has the capacity to be their best. It doesn't matter what their background is. And I'm also here to say that our commitment is to make sure that Lakeridge Health is a fair and just work environment, as well as a space where people come to receive care. Broadly speaking, that's our goal. Now, why it matters to you? It matters to you because as women, we're not a single story. And we've talked a bit about some of those examples. That intersectional identity matters. That intersectional identity also calls us to action to make sure that anytime we have an opportunity, that we're able to bring people along, but not only people who look like us or who we can relate to, but to everybody, and also to learn from each other. But here's what a room generally looks like, even though this room is beautiful with all these women. The statistics would say that in 2022, violence against women increased by 27%. We do work in a workplace that is primarily women. So let's hold that. Secondly, the wage gap between women and men is 84 cents. But when it is a Black woman, it is 69%. When it is an Indigenous woman, it is 67%. When it is a newcomer to Canada, it goes even lower depending on their work conditions or their industry, but we're still looking at potentially around 59 cents. 42.7% of Canadian physicians are now female. Yet they remain underrepresented in women's leadership. Only 13% of women are system leaders. Graduate 42.7%, but we're at 13% in terms of hospital system leadership. In academic medicine, just 20% of department chairs and 18% of medical school deans are women. We have work to do, but that's okay. This is where we come in. Yes, this is where we come in. All right. So IDAA, some of the work we do, so we could talk broadly, but on a practical scale, we're invested in equitable hiring and promotion. And so we are part and working in partnership around talent management strategy to make sure that we're looking at the metrics of who's getting hired, who's getting promoted, so that we make sure it balances and it's proportional to the communities we serve. We're also in the process of supporting a leadership development program that will be looking at mentorship and sponsorship, so that for some of us who don't have families and connections that would have given us opportunities to progress, have at least an individual, peers, or a sponsor to support our growth, our career growth. We want to make sure that we're creating a workplace that is flexible and has inclusive policies. That means we're looking at hybrid workplaces, we're looking at other retention mechanisms that will make sure that you can feel seen, feel heard in the workplace, but also what was mentioned earlier in terms of when you come to get care, that we have the capacity to see you. We're also looking at how are we going to measure the work we're doing. So what are our accountability systems and metrics? So that includes things like our performance system. We're now asking questions about equity. That looks like redesigning our complaints process so it's more nuanced to be able to pick up complexities, especially around discrimination, whether it's gender discrimination, whether it's around sexual orientation, the list goes on. We're also implementing human rights services, which will make sure that we now continue to adhere to the Ontario Human Rights Code. So, what's my call to action for all of us? In my culture, we talk about women are the pillars of society. And then I don't know how many of you would have seen campaigns that would say, educate a girl and you're educating a nation. So I really believe in the power of women. I believe in the power of you in this room right here. And so my ask is that we continue to lead with purpose and authenticity. So stay true to yourself and lead with courage. The second one is continue to build strong networks. We need each other. And that is the one thing that is quite special with women, our capacity to build coalitions and collaboration in moving forward. Embracing lifelong learning. That is the work we're hoping that will allow us to continue to grow and to make sure that we be curious about each other in order for us to be the best versions of ourselves. Challenge the status quo. Remember, you're here because somebody challenged the status quo. So now the baton is on to all of us to try and do that. And then lastly, recognizing our strengths and take risks. So one thing that's very interesting is that for many women to consider a position, they generally would like to have over 100% of the qualifications that are needed. And that's not always the same for the male species, I would say. So anyway, in conclusion, I do believe that women bring transformative power to leadership. And IDAA is here to dismantle systemic barriers and build a future where inclusion is not optional, but the foundation of how we choose to lead. Thank you.
Good evening. As I said before, my name is She Gathers Flowers by the Water, Gagio Yanela. Susan Bernasso, and I'm a crisis intervention counselor with Victim Services of Durham Region. I'm here talking to you tonight on the 19th anniversary of the passing of my Nan, who brought 16 children into this world, 13 of who survived. I'm one of 39 first cousins from the beautiful tropical island of Newfoundland, very proud. And if she were here tonight, she would probably be pretty interested that I'm in a ribbon skirt and that I identify as Mi'kmaq, because she did not have the capacity or the ability to identify as a Mi'kmaq woman. Her father, who was also Mi'kmaq, did not have the capacity to identify as a Mi'kmaq man because it would have affected his trade in the fish industry in Newfoundland when he was alive. And so I'd like to think and I know she's here watching me this evening on St. Patrick's Day, because she really loved this holiday and she passed away on this day on purpose, so we'd never forget, that Rose would have a few things to say about all of her insides falling out after having 16 children and about the way she navigated the healthcare system in Newfoundland. But I'm speaking to you tonight as a woman who lives with a physical disability. I'm speaking to you as a woman who lives with a rare genetic anomaly of the ATP1A2 gene, who in 5 databases worldwide they could not find. I'm speaking to you as an Indigenous woman of a mom of a kiddo who had her first TIA in 2019, and when I was at the workplace, I got a call that my child had had a stroke, and they rushed her to your Lakeridge Health Oshawa facility because they thought she'd had a stroke. And I'll never forget the paramedics that stayed with her until 10 o'clock at night. And I'll never forget the doctor who called sick kids after he got off of his shift after she was rushed into Toronto to make sure that my kiddo was okay. But I also won't forget the nights that I go into some of your ED departments and I have to beg a doctor after I'm done screaming at them that my child just needs an IV in her arm to get those medications into her brain to stop the migraine that could potentially take her life. Or when I go myself and I have a similar experience because I just have a migraine, and what you don't know about my migraine is that it could cause a catastrophic stroke and I will pass away. Because there aren't a lot of physicians that know a lot about my rare genetic anomaly. And so after we're done having a few choice words, and I try very carefully to be very patient and very kind, because I know how tired doctors are, and I know how strange your systems are. And I will say, let's have a conversation about what it looks like to be in my shoes living with a hemiplegic migraine. And as an Indigenous woman, I have learned something very valuable, and that is one of the most amazing things that I have is a neurologist who also identifies as Indigenous, who adds 15 minutes onto my appointment when he has the capacity to talk about Western medicine. But then the last 15 minutes of my appointment, we talk about my spiritual well-being, my emotional well-being, the diet that I'm supposed to eat as an Indigenous woman that will change the physiology of my brain and my well-being. And I'm also a crisis intervention counselor with victim services, and so I come into a lot of your ED departments with victims of domestic violence who are so terrified to be there that they will give anything not to go. And so as a community partner who spends a lot of time there, I spend a lot of time getting to know your staff, getting to know your departments, being a part of evenings like this evening as a community partner, because that's my commitment to my community, which is to sit here at events like this and to partner with you to help you understand the Indigenous narrative. And that trauma-informed care needs to be at the very center of everything that you do. Not only trauma-informed care for your patients, but trauma-informed care for every one of you that work at your hospitals, that work in your offices, that work in your clinics, because the work that you do too is just as important as the patients that you serve. I can't walk in everybody's shoes, nor can you walk in mine, but what I can ask for is that listening to actually hear instead of responding, even if you don't have the answers. And that's how we walk together in reciprocity, from that very offering of tobacco tonight to my sisters and I, to the ability for us to sit here this evening. It doesn't matter what walk of life you come from, every single person in this room is important. And so I know that my Nan is here with me this evening, and I know that when my daughter was born in 2004, she came to Ontario at 84 years of age. She'd never been on an airplane. You need to understand that Rose was very Catholic. And so she traveled with her rosary beads everywhere she went. And the night that Amelia was born, in a snowstorm in December, she walked into a hospital in Toronto because she double dosed on her warfarin. And she looked at the doctor and she said, "Now, my darling, my granddaughter's out in Oshawa and she's in the hospital and she's about to have a baby and I need to be there for that." So she said, "Give Nan a holy hug and you send me to Oshawa because I know that there are doctors out there that are going to take care of me." And that's what she did. They took the IV out of her arm and they let her go with my dad, and she was at that hospital that night when Amelia was born. And they looked after her while she was there. And so I will never forget that gift that I was given that night. And I think it's really important that we never forget the gifts that we are all given in this life, and that we choose to walk on this journey, and that we choose equity and diversity and inclusivity every day, and that we choose the well-being of our employees, and we choose the well-being of our communities. And if we wake up every day and we commit to that, then I think we're okay. Well, Aliak.
Okay, so that concludes our Revolving Doors series session. And for the final concluding remarks, Nadia, please take the stage. So a little bit about how this event came to light. So a couple of months ago, Dr. Ismail and I were having a simple conversation about our personal and professional lives. And it was in that conversation that an idea sort of sparked. And we both sort of asked each other, wow, Durham Region looks so different. Doesn't look like what it used to look like. How can we connect with, learn from, and give back to the women, the real soldiers of all of our families? How can we give back to them? And another question we asked is, how can we empower them to be their master of their own destiny, whether it's about their own health journey or a career in healthcare, whether it's on the clinical or non-clinical side?
So it was an amazing journey together. I attended a meeting last year. It was the Federation of Medical Women of Canada. And there was a conversation about issues which are very specific to women. And they talked about it and they called it snippets. So it was like 10 minutes about every issue that women face, whether it's osteoporosis, whether it is arthritis, whether it's perimenopause, and all things that we talked about today. But that took me back to my own journey. What you're looking at today is a physician, is a health system leader, who is at the senior leadership team at Lakeridge Health, which is a huge privilege for me. But at the same time, the same person is actually an immigrant from a country which was war-torn. And I immigrated to Canada more than 20 years ago. And it's been quite a journey, because you arrive here, you're broken, you're afraid, you have kids. My husband and I were, we spent everything by the time we arrived here. And I remember being pregnant with my second child here in Canada. And we couldn't afford maternity clothes. So I used to wear my husband's shirts throughout my pregnancy. So I've come a long way. And one thing I would say is that I'm looking at some women here, and I think I see the story of immigrants. And I also see the story of cultural shock that we receive here when we come to a new country, a new place, people that we don't know. So that is probably, I would say, the first generation immigrant, if you will. And here is the second immigrant. Come on.
So similar to Dr. Ismail, I am a second generation immigrant. And so what that looks like for me is that my parents, they were forced to flee a war-torn country, what we call Tamalulam, or northeast of Sri Lanka. And because of some of the sacrifices that they were forced to make, I now have the opportunity to really pursue a life of freedom, ambition, and so-called peace. But as whether you're a first-generation immigrant or a second-generation immigrant, one thing that rings true for all of us is that this pursuit of freedom, it comes at a cost. And oftentimes, that's your mental health. And for many immigrant communities, communities of color, or equity-deserving communities, as some would like to call it, there's that generational toll for when it comes to mental health, or the impacts of just generally what generational trauma does to you. And so I say this because my family and we went through the same thing in different ways. And growing up, it didn't also help that on the mainstream media or in corporate boardrooms, there wasn't really a lot of people that looked like me or had the same experience as me. And so as a young, marginalized Tamil girl or woman, I could have never dared to dream of a moment where I could be sitting next to one of the most badass women that I know today.
So the journey is not an easy one. It's not, like one day you wake up and you are in this position today. There are so many roadblocks. So whether it is starting all over again, doing your exams all over again as an international medical graduate, moving from one place to another in Canada to basically pursue opportunities and dragging your kids with you. And in addition to that, the generational and cultural issue that we have with our own kids who grew up in a different country. But at the same time, each time, it always reminds me of the resilience of women. We as women are so resilient. And we are so three-dimensional. We can always adapt no matter what. And I think that is, and also when I always remember my mom, I remember my aunts, I remember the generations of women in my family or my friends who came before me, and that gives you a lot of strength to carry on and to stay the course and focus and almost like put a goal and reach that goal at the end. And I feel that, it's a privilege, but at the same time a burden, because you always feel that you need to pass it on. It shouldn't stay with you. It is through mentorship, it's through reaching out, it's through looking at these amazing women here. I'm looking at you and I'm saying, you are the anchor of this society. You are the future of all the new generations which come in. So own your destiny, own your power, make sure that you achieve whatever you want to achieve, and build this community, make it stronger, make it better. And we at Lakeridge Health are here for you, because to be honest with you, when you look at these amazing women who did all these presentations, look at them and see yourself in each one of them. And hopefully, like the new generation that will lead Lakeridge Health will be sitting here among these young women here.
So before we conclude, I do want to say, Lakeridge Health, we are a large organization. We are a healthcare system, one of the biggest community hospital healthcare systems in Ontario. We are not perfect. We're not going to always get it right, but we do care, as Dr. Ismail said. We care about your well-being. We care about the collective good health of Durham Region. And the only way we can do better and we can care better for you, if that makes sense, is by you walking along the journey with us, or us walking with you. We need to hear from you. We need to know what we can do to ensure that your unique health needs are being addressed in a culturally responsive way. So what I ask from you today is, first off, we do have the QR codes on every single one of your tables. It's also on the agenda. It's on a lot of different communications or posters across this venue. Please do take the time to to tell us what you think. Your feedback is important so we can continue to shape the services and programs that we offer at Lakeridge Health. Before I conclude, I do also want to say thank you to our sponsors, Ontario Power Generation, Ajax Pickering Hospital Foundation, Bowmanville Hospital Foundation, Lakeridge Health Foundation, and Port Perry Hospital Foundation. This amazing event truly wouldn't have been possible without your support, and we look forward to continuing to have your support to deliver more programs that are catered to our unique community groups that exist in Durham Region. Thank you.